Hello everyone, this is I Yonis. I am an emergency medicine doctor. I work for Ipsum and St. Helier University Hospitals NHS Trust. I would like to talk to you today about the ultrasound scanning for abdominal aorta and inferior vena cava in the emergency setting. For aorta, for abdominal aorta, ultrasound of abdominal aorta in emergency medicine is routinely used for screening and monitoring of aortic diameter to rule out or rule in if there is any AAA, and recently became an increasing procedure we use normally in A&E in UK. It helps us to make the critical management decision earlier, and it is used in early identification of abdominal aortic aneurysm. In the emergency setting, we need to concentrate on one thing, or two things, which are the most important thing with aorta, whether if there is abdominal aortic aneurysm or not. So we have to be binary in our decision. The thing is, the other stuff, which is the most important thing, is that ultrasound scan is not accurate in determining the presence of a leak of aneurysm, so we need to do further investigations for some of the patients. You can see here it is a highly sensitive and highly specific in determining the AAA in emergency department. They found that it reduces the time to diagnose the ruptured abdominal aortic aneurysm. The mean time of 180 minutes was reduced to 80 minutes, so it's a reduction of by 100 minutes, which is highly significant for the patient, and it is really crucial to diagnose as early as possible. Also, the time to CT scan is reduced as the time of operative repair. So what we normally use, so when the patient comes to A&E with abdominal pain, we do an ultrasound scan. We feel that there is like a AAA. We send the patient straight away to the CT scan then, which means that the time to do the CT scan is reduced, and then therefore the time to reach the diagnosis of such condition is reduced as well. So the combination of an abdominal aortic aneurysm on ultrasound and unstable symptoms in the patients who present to ED is enough to warrant an emergency vascular surgical opinion. So there is no point to waste your time with that one. AAA is 1.5 of the normal diameter of the abdominal aorta. Less than 3 centimeters in diameter is normal of the aorta, and more than 3 centimeters in diameter is AAA. So we keep in our mind the AAA. So the AAA means that which is like 3A's. So more than 3 is the diameter of the suggestion of the AAA for a certain patient. It's unlikely for the AAA to rupture if it is less than 4 centimeters. So patients probably will come to you with abdominal pain. We do an ultrasound scan to check if there is AAA. We find that there is AAA, like it is 3.2, 3.5. It is not. It doesn't mean that this patient has a rupture. We have to search for other causes, of the abdominal pain. Could be this one, but we need to do just to search more for other causes. The risk of rupture increases if the diameter is more than 5 centimeters. So then, when we see more than 5 centimeters and the patient is not in a severe condition or is not hemodynamically unstable, so there should be an elective surgical repair. We consider the surgical opinion through the vascular surgeons. So the AAA is common in patients more than 50 years old, and males are more than females in their percentage, and ultrasound scanning or screening program for males of more than 65 years old is designated for those patients, for everyone who is over 65 years old, to rule out the abdominal aortic aneurysm. What are the presentations of AAA? There is sudden abdominal pain, flank or back pain. Patients may present with syncopal attack. Patients may have a hemodynamic instability, low blood pressure, fast heart rate because of the leak of the aortic aneurysm. Vast majority of patients, they present too with like asymptomatic with regards to the to this type of presentation. So those are here the we can divide them by the common presentations and presenting symptoms when rupture occurs. So we have syncopal attack, sudden onset of abdominal pain, hypovolemic shock, and less common presenting symptoms, distal embolic features, aortocaval fistula, primary aortointestinal fistula, or sometimes hydronephrosis as a result of the pressure of the aorta, abdominal aorta, to one of the ureters. In the anatomy, we can see here, this is the diaphragm. There are 3 orifices in the diaphragm that transmit the structures that we always know. Inferior vena cava leaves the abdominal wall at the level of T8, and aorta enters the abdomen at the level of T12 and bifurcates at the umbilical level in L4 to the right and left common iliac arteries. You can see here, so this is the abdominal aorta, and here this is the inferior vena cava. There are many branches from the abdominal aorta. We have the celiac axis, right, it will be at the level of the T12. This is the celiac axis. The celiac axis gives us 2 branches, the common hepatic artery and the splenic artery, and we have the left gastric artery, and we have also the superior mesenteric artery, which is a branch of the abdominal aorta in the lower level. It's 1 centimeter below L1. We can see this is the inferior mesenteric artery. We have other branches. We have the right and we have the right and left renal arteries, and also we have the inferior mesenteric artery. Those arteries, frequently we don't see them in the ultrasound in emergency setting. Bifurcation of aorta into the right and left common iliac artery in L4 level. Here is also a very nice picture of the abdominal aorta, and this is the celiac trunk. This is the superior mesenteric artery. This is the aorta, and we can see here the inferior mesenteric artery with its branches. Right. Scanning of abdominal aorta, usually we have to use the low frequency curvilinear probe, transverse orientation, which gives us the short axis, scan down continuously to the level of the umbilicus, and then change the orientation of the probe to the longitudinal axis or long axis, and slide down again, and we have to keep in the abdominal aorta in the middle of screen. Normally we use the focus depth of 10 centimeter and length depth of 15 centimeter. Right, so we can see here, this is the first point to scan, which is the epigastric area, and go down, scan the other point, which is the middle area, and then we'll scan to the other point, which is the umbilical area, and then we change the orientation of the probe to the longitudinal one and go all the way down. Right. We have to make sure that we are keeping the abdominal aorta in the middle of the screen all the time. A sufficient depth is essential to see the vertebral bodies at the back of the image. So make sure that firstly you are going to see the vertebral bodies, and then from the vertebral bodies we'll see all of the other structures. The main features of the abdominal aorta are, first of all, the location. It locates on the left side of the midline of the patient, so on the left side of the vertebral body. Thick-walled, will not compress, pulsatile, round, constant in shape. So those are the features or the scanning features of abdominal aorta. While the scanning features of inferior vena cava, we can see that it is on the right side of the vertebral body, thin-walled, compressible, and transmitted pulse. We see like it is double bounce pulse, almond and in shape, and this shape varies from one point to another. Measurements. In the transverse orientation, we have to ensure that we are completely perpendicular, while in the longitudinal orientation, we have to ensure that we are central in the abdominal aorta. So make sure that we are central. Our prop is in the central position, and if there is any hematoma, we have to include it. Right. So you can see here. So this is the way to measure the abdominal aorta. It's a longitudinal way or perpendicular way. Don't go to the transverse way. And this is the transverse orientation, and this is the longitudinal orientation. And you can see here there is this is the way how to measure the wall or to the diameter of the abdominal aorta. Right. How can we with the interpretation? We just let you know that it is highly sensitive and specific. And it is used to rule out or rule in the AAA. Doesn't tell if the AAA is ruptured, so we have to use other clinical assessment, or we have to depend on other clinical presentations. So the patient is hypovolemic, shocked, in severe pain, and we see the AAA. And which means this gives us an idea that this patient has a rupture. So we don't see the ruptured aortic aneurysm normally in the ultrasound scan. Ruptured AAA diagnosed by a contrast-enhanced CT scan. So starting from the first point, which is the epigastric area, we can see here, we are going to see those structures. So we are going to see the celiac trunk with two branches. So we cannot see the third branch with it, which is the gastric one. We will see the two branches because the gastric one goes anteriorly, so we won't be able to see that branch. So now there are steps. First of all, you scan the area, find the vertebral body, find the inferior vena cava to the right side of the midline, and then you will find aorta on the left side of the midline. Okay, so celiac axis, its hepatic and splenic branches, forming what we call it Siegel sign. So we can see here, this is the Siegel sign, you can see it, okay, and here is the abdominal aorta, and here is the vertebral body, and also you can see here, this is the inferior vena cava. All right, this is one of the ultrasound pictures of the ultrasound for the aorta. So we can see again here, this is the Siegel sign, right, and abdominal aorta and vertebral body with inferior vena cava. The second level, which is the middle level of the abdominal aorta, we can see here we are going to see the middle of the aorta, so we will be able to see the superior mesenteric artery in this view. So also scan the level below, go to the find the vertebral body first on the back, and then inferior vena cava to the right side and aorta to the left side. So superior mesenteric artery just above the aorta. These are those structures, superior mesenteric artery, abdominal aorta, and the vertebral body, forming what we call it snowman. So you can see here, this is the snowman. So this is the superior mesenteric artery, this is the abdominal aorta, and here this is the vertebral body. They form all the snowman appearance. we are going to have a look here. See them, those are the superior mesenteric artery, abdominal aorta, and the vertebral body. You can see other structures. Those other structures are, you can see them here. You can see the first one is the liver, and then after the liver you can see the pancreas and the portal vein here, superior mesenteric artery, and you are going to see the left renal vein, abdominal aorta. Left renal vein joins the inferior vena cava, and abdominal aorta here with the vertebral body. Okay, let's have a look again. This is the snowman appearance. Okay, we have a look again here. In this photo it will be a little bit more, you can see it here. Right, here we go. Right, this is the snowman appearance. Right, now after you finish, when we do the transverse section or transverse section or transverse axis, we go to the longitudinal axis. So here you can see this is the prop. Have a look at how we are going to change the prop. Changing the prop, we will rotate it to make the marker, the prop marker, facing the cephalic end of the patient. There we go. So you can see the abdominal aorta in the longitudinal section. So this is the abdominal aorta, and this is the longitudinal section of it when we change it. Right. This is a very nice photo or image. You can see that this is the abdominal aorta here, abdominal aorta, and this is the celiac trunk, and this is the superior mesenteric artery going down. So if you have a look, you can see if you just play with the prop right and left, you will be able to see the proper branches. Right, going down to the lower level, from the level of the superior mesenteric artery, lower down we will see the distal aorta, and after that, once we see the distal aorta, we'll go down to check less than just below the umbilicus. We'll check the bifurcation of aorta to the right and left common iliac artery. I normally go down to see the bifurcation and have a look, because sometimes you will be able to check if there is any abnormality in one of the common iliac artery, as we did. One of the patients presented with left lower abdominal pain, and we just did the ultrasound. We went down to see the bifurcation. Then after the bifurcation, we found that there was an aneurysm on the left common iliac artery. So how to scan it? We will go the marker on the right side of the patient, and we put it on the transverse level, scan and find the vertebral body, inferior vena cava to the right of the midline, and to the left is the abdominal aorta, then its bifurcation to the right and left common iliac arteries. So we can see here, this is the abdominal aorta and this is the vertebral body. You can see that here is the vertebral body. You can see the abdominal aorta is bifurcating to the right and left common iliac arteries. Yeah, so we are going down, scanning, and this is a bigger image. You can see here. You can see the abdominal aorta bifurcating as we're going down to right and left common iliac arteries. There are different forms of the aneurysm, actually there is a fusiform or circular shape or hourglass appearance. These are different shapes, and they all present with the same symptom, abdominal pain. If it is ruptured, there will be a collapse or a severe abdominal pain, and other symptoms, because the pain will be radiated to the flank area. This is one of the images of the abdominal aortic aneurysm. You can see all of this one is an aneurysm, and there is a hematoma or a clot formed. So if I want to check the dimension, I start from here, going all the way down, include the thrombus. So include the thrombus. And this type of aneurysm, we call it smoking aneurysm. You can see here inside. Looks like this is the smoking aneurysm. Right. There is another, this is a longitudinal view. And you can see here, if I want to make the dimension, I will go from up, down. So you can see this is up and down. Okay. And here we can see there is a flap of dissection. Can you see this flap? So there is a flap of dissection of this abdominal aortic aneurysm. So this flap is moving with the pulsation. You can see it there. So it is dissected. So some of the blood goes within the flap. Right. And here we can see that this is all aortic aneurysm. And you can see this is the lumen of the abdominal aorta. So I'm gonna take the dimensions from here down to here. Okay, so here you can see this one as well. Right. One of the things that we may face when we do the abdominal aorta scanning is that some of the patients, they will have bowel gas, or well, like very high percentage of patients, they come to us with bowel gas while we do scanning for them. So the patient, we can do several things to overcome these bowel gas. In supine position, we do flexion of the knees and hips. This may help. Deep inspiration may help as well. When you ask the patient take a deep inspiration, so this will the diaphragm will press down, and then this will cause the gas to go down. And sometimes we can slide the props laterally. We will be able to see the abdominal aorta. If these things are not working, and in parallel with the deep insertion, or we push the prop deeper to the abdomen. Sometimes the patient present with abdominal pain. They won't allow you to do that. They will jump because of the pain. Leave the patient for a few minutes and come back to them again to do the ultrasound scan. If all of these measures are not helpful, we have to do the CT scan to rule it out. The pitfalls from scanning of abdominal aortic aneurysm, abdominal aorta, ultrasound scan of abdominal aorta are misidentification of the aorta. So use the deep exposure, find out the vertebral body, and then you will be able to find the abdominal aorta. This is number one. Number two, mismeasurement. As we said, we have to go perpendicular, include if there is any thrombus inside the abdominal aorta. And misinterpreted findings, you have to learn where to find the aorta in relation to other structures in the abdomen. In the inferior vena cava scanning, in the subcostal view, use curvilinear probe with the marker towards the patient head, and the dimensions will be 1.5 to 2.5 centimeters. These are the normal ones. 1 centimeter from the hepatic vein. Normally, the inferior vena cava collapses 50% with the inspiration. If we see hypovolemia, we'll see that if the patient has hypovolemia, we'll see that the IVC will be small. Or if the patient, if there is an enlarged, non-collapsing, plethoric inferior vena cava, this indicates that the patient has obstructive shock, either PE, pulmonary embolism, or tamponade. And this is the position of the probe. The marker will be facing towards the head, and this is the epigastric area to see to scan the inferior vena cava. We can see here, this is subcostal view, and this is the inferior vena cava while it's entering to the heart, and you can see it's collapsing with inspiration. It's about 50% of the collapse. This is normal for the abdominal aorta. Abdominal view of the inferior vena cava. And here we can see that this is the inferior vena cava, and this is the heart, and you can see that there is some fluid here in the heart. This is the pericardial effusion. So we'll see how the inferior vena cava behaves when we do an ultrasound scan. You can see that it is plethoric, engorged. It's not reducing with inspiration. So this is increased, or this is in obstructive shock. Here we can see that this is the heart, this is the inferior vena cava, and this is a case of hypovolemia. Look at the inferior vena cava is collapsing, and the edges of the wall, they are kissing each other. So this is what we call it in hypovolemia condition. So we can use the ultrasound in patients with a collapse. So with the collapse, to check if there is any hypovolemia or if there is any engorgement of the inferior vena cava, and also we'll check the abdominal aorta to see if there is any other symptoms related to the triple A. To take home message, it's really important to take care of identifying aorta. This is really important. You have to dedicate yourself to identify the aorta and how it looks like, and where is it, and what's going on with it. Is it triple A or not? We are not radiologists. We are emergency medicine physicians. So we just need to rule out if there is any rule out or rule in if there is any triple A or not. So we have to be binary thinker. Focus depth will be 10 centimeter is enough, and image depth will be 15 centimeter, which will be enough. Be careful when measuring the diameter of the abdominal aorta. Include the thrombus if there is any thrombus. Save the images. We need them. You will not rule out triple A unless you can see the entire length of the aorta. So it's not to see, for example, the middle of the aorta, while you are not able to see the epigastric or lower level. So see entire length of the aorta. If you find triple A in the first view, so you can stop because you diagnosed it, and that's it. That's the most important thing. Bowel gases, they are the most common like finding. We can find they interrupt our finding to see a normal picture of the abdominal aorta. Try direct pressure with the probe. Patients with the high BMI, the fat people, reduce the frequency and reduce the grayscale. You will be able to find out the aorta. Measure the outer wall diameter. It's really important. And patients sometimes they present with urinary retention. The size of the urinary bladder sometimes may mimic the triple A, so be careful with that one. You have to make sure that the patient is not in urinary retention. And that's one of the most common thing you have to keep in your mind. So if the patient comes to you with a renal colic picture of pain, and the patient is old age man, put in your mind there is a possibility of having AAA. So you have to do the scan for this patient. So you have to do an ultrasound scan for them. And last thing is that you need to clean the machine after using using it for the diagnosis. Thank you so much. I hope you enjoyed this presentation, and I'm more than happy to have any questions.